welcome everybody to SCTS in Edinburgh. I'm very, very privileged to have with me today an esteemed panel of guests. I have Dr. Petersen here from Copenhagen, we have Professor Colson here from Mass Gen, and we have Novoa from Madrid. So I'm really, really excited. We've had a very exciting talk today about the way thoracic surgery has really evolved over the last 5 to 10 years. In fact, we could take it 5 years and so much has happened. And we thought we'd just bring to you our feelings on what's happened, where we've come, where we're going, and how exciting the specialty is to work in. So I'm going to move over to Professor Colson perhaps to start. We were talking a minute ago about where we've come from and how depressing thoracic surgery was back in the day. That's a good place to start, and then we can talk about where we've come to.
It wasn't depressing, it's just that you wanted so much to make a difference, and you couldn't make a difference for nearly as many people. And so either it was that we had to do really large operations, which we knew were going to be really hard to recover from, or we were giving them multiple therapies that were maybe not as effective, and the recovery, and then you would get through all of that, and the recurrence rates were higher. They would get back some metastatic disease. And it was really this act of love to go through it. And the medical oncologist and you were together at the hip, just trying to get through and make a difference. And it's still an act of love, but it's a much better group to be, because now things are so much smaller. The operations are so much kinder, if you want to say that. And I think it makes it so it's so exciting to know I can take somebody who I could not have treated before, and we can do it. And the likelihood is, we were looking today that some of these people who were not resectable and we didn't have options are now 90% 4-year survivals if they clear their ctDNA. That's like unheard of.
Yeah, absolutely. No, I totally agree with you. But it's not only from the point of view of let's say survival in patients, it's also what what are we doing? Just, technically.
Yeah.
Yes, I remember when I was a resident trying to do bronchoplastic procedure, arterioplastic procedure, it was like, oh my God, it's the chief who is coming and is doing this procedure. And nowadays, they are becoming routine. So it means that we are changing absolutely everything. We are changing from the patient, that's what you mentioned, but it's also changing from our point of view also, which is quite interesting. I feel much more, I don't know, much more with not only my patients, but also with myself.
Well, technically.
Because technically, you can do much more things.
And we're doing it minimally invasively as well.
Right.
Yeah, absolutely.
Yeah, I think we've been very fortunate in our generation of thoracic surgeons. We've been facing, I think, a revolution, moving from very big incisions to very small incisions, and enhanced recovery. Focus on enhanced recovery has really improved patient outcomes. So today we're operating 80, 90-year-olds that we wouldn't touch 10, 15 years ago, and they are actually doing very well. We have very good results. We have short lengths of stay. We have very low mortality rates, and we have better and better survival rates, I think. And that is minimal invasive surgery has come to, I think, another step point now with the multimodality treatment. Neoadjuvant immunotherapy is making surgery more complex, and we need more tools, I think, to facilitate minimal invasive surgery in these more complex operations. So first of all, we do more tailored surgery, and I think now lung-sparing surgery, but also we need more tools like robotic technologies, which is evolving very fast right now. So many companies on the market, and a constant development of robotic surgery, I think, is going to promote minimal invasive surgery in these very complex situations, and maybe even automated robots at some point.
At some point.
Sure. Joel knows a lot about that. But no, we're facing I think we're so fortunate because we are facing a constant development, and I'm sure that 5-10 years from now, the results for lung cancer patients will improve dramatically.
Yeah. Well, I think the other thing is that it says something about our profession, because I think the thoracic surgeons have been really innovative and have embraced it and supported each other in the fact that there is all this advancement, and the multidisciplinary working with the medical oncologist and working with your pulmonologist and the interventional radiologist, that community. And maybe it's because there was this big rally of everyone was together trying to make this horrible disease treatable. But there has been a lot of enthusiasm to try new things. Mm-hmm. And I think there is an energy that has kind of always been there, but particularly now. There's not we shouldn't do this. Or people will try things and then they vet it and make sure that it's safe and it's appropriate. But the energy in our specialty of doing new things and making a difference has always been strong, but it's a particularly great community, I think, globally.
Yeah, I agree with you. This is something that I was somehow stressing this morning, because when I was talking about proms and prems, we are not only looking at what is happening to the patient, but also what is happening, how they are experiencing their path through the disease. So we want to know what is important for them to improve ourselves. Mm-hmm. And this is not something that is not happening in all the other specialties. Mm-hmm. So somehow we are a little bit different. I don't know, maybe because we were the little kid of the cardiac surgeons, and then we need to improve a lot. Well, this is I'm not serious, but
we make these relationships with our patients for years.
Yeah,
and I think that's part of it, because they become part. It's not like we do something and they go on. So that is a really fulfilling part for me, that I've known people for a long time. And I think that is one of the things that attracted me to the specialty, was I could have a relationship with people that you could really know for years and take care of. Because I think lung cancer and esophageal cancer are these things that you have to watch for a while. It's not a one and done, so I think it's good.
Even more so now in the era of more long-term follow-up, potentially picking up recurrences, new disease in more than our initial 5-year follow-up, and then that's it. Correct. We're done. We're not in that era anymore. I think we've moved on beyond that. And you were talking some really exciting work on novel therapies and predicting those who will have recurrences. Mm-hmm. I think those things are super exciting moving forward.
Yeah.
Yeah. It is, but it has indeed also become much more complex. It used to be very easy. Yeah. Patients should either have a lobectomy or a pneumonectomy, and that was it. And now everybody needs a tailored treatment. Then this may be some new adjuvant treatment, then maybe surgery, then maybe some adjuvant treatment, and then maybe again at some point some radiation, and then maybe again surgery. Mm-hmm. Maybe for brain metastasis, whatever. It's going to be so complicated now, and it's all depending on the different biomarkers, and we get new biomarkers every day. We get new mutations that's going to guide treatment. So, and in an era of artificial intelligence, I'm sure we need to develop tools that can help us aid exactly how to treat a patient with this and this subtype of tumor, with these biomarkers, with these mutations, what is and with this age and this comorbidity, what's going to be the target treatment for this patient?
Yeah,
truly personalized.
It's like chess, right? Now it's become a real chess game.
It is.
How do we win?
Absolutely.
If everybody had to pick not betting, but their kind of key thing for the future. If you had to pick one thing that you think is really going to drive the specialty forward, something that you're particularly interested in, that you see coming to play in the next 5 years, what would you pick? Let's go around.
Maybe I will see a lot of new technical improvements. I think that as René was mentioning, I think we are going into a phase in which machines, they are going to learn to operate themselves, so we are going to be behind them, or we are doing the procedure and then the machine is just correcting us. I don't know who is going to correct who, but I think that's not only from the robotic side, but there are a lot of technical improvements that are coming. I'm totally aware that what you were mentioning in this last session, it's going to be very interesting. how to deliver local treatment, not in let's say in the fashion that we are doing now. Yeah. So I think this is the way we are going.
I'm going to let you talk about AI because I totally agree. But I do think the surgeon has the ability to think about disease differently. And we really we don't think about the lymph nodes. We don't think about ways to that. We think about systemic disease. And so I do think we're going to start moving into an era where we can do much bigger surgeries and much more to do, but then thinking about how the surgeon can make their operation better. How do we make sure that we can we get all the nodal disease and then we don't have to worry about the fact with IO that it's become sclerotic or it's become really hard if we know we've cleared that disease? Are there ways for us to target those? Are there ways for us to come out with meshes that can prevent recurrence? Are there ways for us to increase our operation and the effectiveness of our local control operation? So I think there's going to be a whole new era of advancing our treatments with less morbidity, and I think we'll continue to evolve that. And I'm going to let you do what I think is really cool.
But I think we also have to focus on things are getting more complex, which means that we also have to focus on training. It's extremely important that we train and educate. Because it's becoming more complex, and I think also subspecialization is something that is necessary because some of these treatments will be very complex, and you need to have a certain volume to handle these very complex operations in a minimal invasive way. Because if we do not have like a very good offer, there will be other treatment modalities. So we should really develop what we can do as surgeons, what we can deliver for patients should be fine-tuned. And I think this requires centralization, subspecialization, and very good training of skills using simulators and all the technologies we have.
We get all excited about the bells and whistles, but technical excellence and quality, we don't have anything if we don't have those two.
No, completely agree.
Absolutely. Absolutely.
And just to play devil's advocate in this exciting environment, are we at risk of new technology like you were talking about in the last talk with potentially intratumor drug delivery, hydrogel delivery? We could potentially deliver targeted therapies direct to the tumor. Are we going to put ourselves out of a job?
I think stay focused on the patient. If there was a pill you could take and it makes your lung cancer go away, I'm okay losing my job, right? But I'm not okay losing my job for a worse outcome because it's easy. And so I think if we keep focused on the patient and always do what's right for the patient to get the best outcomes and do it the best way we can, then we'll be fine.
Yeah, I absolutely agree. I think that I like very much the changes that we have done from the, let's say, everything was from the surgeon perspective to now to the patient perspective. It is something completely different. And I think that they are really the center of all this. And as much as we keep this, things will be
I don't think we're going to be out of a job.
No.
I agree. I think it would be very fortunate for our patients if there was a very easy solution that did not involve surgery. But we have to remember for now there's 2/3 of patients who don't get any offer of surgery at all. And I think this with the multimodality treatments development, this pool of patients may be resectable at some point. So I think we're not going to be out of a job for the next, at least 10, 20 years.
But I do think it's really important we stay focused on getting the people offered what is the true best therapy, and that we do not have where it's, but this is easier. It's a little less, and we don't follow it, and they actually don't have, 1-year outcomes. We're looking for what's their 10-year outcomes. And so I think it's making sure that it's not that we lose people to what seems fast and easy.
Yeah.
I think that's our other calling.
So there we have it. for anyone considering a career in thoracic surgery, you've heard it here from three of the greatest in our field, that it's a rapidly evolving specialty. There's lots to do, lots to learn. It's highly complex. There's going to be lots of subspecialties we can get involved in, and there'll be much more to come. So please do keep going, keep considering thoracic, keep doing thoracic surgery to the best of your abilities, and making sure that we standardise our protocols and that we offer the patients the best possible treatment, now looking at 10-year outcomes rather than 5-year outcomes.
Yeah,
And
absolutely.
I think you can have a huge impact.
Absolutely.
People entering the field now can really make a difference.
Yeah, this is really exciting. So keep going.